seminar on surgical site infection. So the first speaker will be Dr. Prashanjit Basu, will speak on the pathogenesis and spectra of surgical site infection. Prashanjit is first year junior resident at MR Bangalore Hospital. Prashanjit, you can share your screen and start presenting.
Good morning, our respected teachers and our all participants. I am Dr. Prashanjit Basu, and I am going to present surgical site infection, pathogenesis and spectra part. What is surgical site infection? Surgical site infection is an infection that occurs in the wound created by an invasive surgical procedure. It leads to increased morbidity, increased mortality, increased duration of hospital stay, 7 days on an average, and increased cost. Types of surgical site infection: superficial incisional surgical site infection, deep incisional surgical site infection, and organ or space surgical site infection. Superficial incisional surgical site infection. Infection occurs within 30 days after surgical procedure and involves only skin and subcutaneous tissue of the infection. And patient has at least one of the following: purulent discharge from the superficial incision, organism isolated from an aseptically obtained culture of fluid or tissue, superficial incision that is deliberately opened by a surgeon and is culture positive or not cultured, and patient has at least one of the following sign or symptom: pain or tenderness, localized swelling, redness, heat. Diagnosis of deep incisional surgical site infection occur within 30 days after the operation if no implant is left in place, or within 1 year if implant is placed and the infection appeared to be related to the operation, and involves deep soft tissue of the infection, facial and muscle layers. For example, facial and muscle. And patient has at least one of the following: purulent drainage from deep infection, deep incision spontaneously dehisced or opened by surgeon and is culture positive or not cultured, and fever more than 38 degrees Celsius, and localized pain or tenderness, abscess or other evidence of infection found on direct examination during invasive procedure by histopathological exam or imaging test. Diagnosis of deep SSI by surgeon or attending physician. Organ space surgical site is infection. Infection occur within 30 days after the operation if no implant is left in place, or within 1 year if implant is placed and the infection appeared to be related to operation. An infection involves any part of the body excluding the skin, fascia or muscle layer that is opened or manipulated during operative procedure. Patient had at least one of the following: purulent discharge from drain placed into the organ or space, organism isolated from an aseptically obtained cultured or fluid or tissue in the organ or space, abscess or other evidence of infection found on direct examination during invasive procedure or by histopathological or exam or imaging test. Diagnosis of an organ or space infection by surgeon or attending physician. Further classifications on the basis of severity. It may be minor or major. Minor, discharge without cellulitis or deep tissue destruction. Major includes pus discharge with tissue breakdown, partial or total dehiscence of the deep fascial layer of the wound. Systemic illness is also present in major case. Or it may be early, intermediate, or late. Early, infection present within 30 days of procedure. Intermediate occurs between 1 and 3 months, and late present more than 3 months after surgery. Microbiology of surgical infection. Common bacterial causing surgical infection are Streptococcus. Streptococcus pyogenes is the most pathogenic. It has the ability to spread, causing cellulitis and to cause tissue destruction through the release of enzymes such as streptolysin, streptokinase, and streptodornase. Streptococcus pyogenes and Streptococcus faecalis may be involved in wound infection after large bowel surgery. Staphylococci infection are usually suppurative and localized. Most hospitals' Staphylococcus aureus strains are now beta-lactamase producers who are resistant to penicillin group of drugs. But many strains remain sensitive to fluxacillin, vancomycin, and aminoglycoside, and some cephalosporin. There are several novel and innovative antibiotics become available like linezolid, which are very effective against Staphylococcus. Clostridia. Clostridium perfringens is the cause of gas gangrene, and Clostridium tetani and causes tetanus after implantation into tissue or a wound. Aerobic gram-negative bacilli. Most organisms in this group act in synergies with the vectors to cause surgical site infection in bowel operation. Koch's postulate regarding infection. The organism must be found in considerable number at the site of infection. The organism should be grown in pure culture from the site of infective focus, and the organism should be able to produce similar deletion when infected into another individuals. Factors which prevent surgical site infection. Host factor or local host defense includes an intact epithelium, which resists penetration by the microorganism, flushing action of tears, urine, cilia, tracheobronchial tree, gastric pH, local immunity by secretion of immunoglobulin A by intestinal epithelium, systemic host defense, which once the microorganism invades the body, complex defense mechanism involves into play to kill the invading organism. Uh, Systemic defense mechanism includes cell-mediated immunity and humoral immunity. Cell-mediated immunity are mainly mediated by polymorphonuclear leukocytes, tissue macrophages, and phagocytes, the invading microorganism, and kill them. Humoral immunity are mediated mainly by antibodies against the invading organism, complement system, cytokines, leukotrienes, and other biologically inactive molecules may take part in killing the invading microorganism. Factors leads to alteration of host defense are malnutrition, diabetes, uremia, jaundice, immunosuppressed individual, advanced malignancy, anemia, post-operative patients. Local wound factors are contaminated wound. Local wound factors are contaminated wound, presence of dead and devitalized tissue, presence of foreign body in the body, local ischemia due to shock or peripheral vascular resistance. Surgical technique is an important determinant of wound infection. Uh, Gentle tissue handling, removing all dead and devitalized tissue, they are all prevents surgical site infection. Achieving adequate hemostasis, optimal use of diathermy, rational use of drains, avoiding suturing under tension. Sir, can I ask a question regarding this? Why avoiding suturing under tension prevent surgical site infection? I found in uh, hello.
Yes, please, Prashanji.
Sir,
Sharp,
why
you finish
avoiding
up.
okay, sir. Okay,
You
sir.
finish up.
Okay. Need to Pathogenesis includes when enteral feeding is suspended during the perioperative period, particularly with underlying disease such as cancer, immunosuppression, shock, or sepsis. Bacteria, particularly gram-negative bacilli, tend to colonize the normal sterile upper gastrointestinal tract, translocate to the mesenteric node, and cause the release of endotoxin like lipopolysaccharide in bacterial cell walls, cause the harmful systemic inflammatory response through the excessive release of pro-inflammatory cytokines and activation of macrophages. In the circumstance of reduced resistance to infection, microorganisms that are not normally pathogenic may start to be a pathogen. This is known as opportunistic infection. This is pictorial description of same. This is definition of some SARS and sepsis. SIRS is of includes mainly hyperthermia or hypothermia. Hyperthermia 30 more than 38 degrees Celsius and hypothermia less than 36. Tachycardia more than 90 per minute, no beta or tachypnea more than 20 per minute. White cell count more than 12,000 per cubic millimeter or less than 4,000 per cubic millimeter. Sepsis is SIRS with a documented infection, and severe sepsis or sepsis syndrome is sepsis with evidence of failure of one or more organs. Respiratory, acute respiratory distress syndrome, cardiovascular, which includes septic shock, follows compromise of cardiac function and fall in peripheral vascular resistance. Renal, usually acute tubular necrosis, and hepatic blood coagulation systems or central nervous system. Role of toll-like receptor and non-toll-like receptors in sepsis. The acute non-specific inflammatory response triggered by endogenous danger signal evoked by surgical injury is beneficial, while paradoxically associated with reduced resistance to infection. Primed inflammation by surgical insult exaggerate the dysregulation of the immune inflammatory response to the invasion of pathogen post-operatively. Innate immune receptors such as toll-like receptors contribute to detecting both pathogen-associated molecular patterns and endogenous damage-associated molecular pattern and to further amplifying inflammatory response to infection. Non-TLR such as membrane-associated triggering receptor express on myeloid cell family, cytosolic nucleotide binding oligomerization domain like receptor and nuclear family 4 subgroup A receptor are also crucial in triggering the immune response and mounting the effective defense against surgical insult and second hit of infection. This is a classification of wound and the comparison with the prophylaxis and without prophylaxis, the chances of infection. In clean, no viscous open, there is 1 to 2% chance of surgical site infection. With prophylaxis and without prophylaxis, there is no variation. Both are similar outcome. Clean contaminated wound, which includes viscous open and minimal spillage, the chance of infection is 3% with prophylaxis and 6 to 9% without prophylaxis. And in contaminated wound, in which viscous are open and spillage or inflammatory disease are for 6% chance with prophylaxis and 13 to 20% chance without prophylaxis. In dirty wound, such as pus or perforation or incision through an abscess, the chance of infection without prophylaxis is quite high, 40%, and with prophylaxis it reduces up to 7%. Thank you, sir.
We can discuss for about 5 minutes.
Yes,
Yeah.
we can. So, Makunda, you want me to ask questions?
Yeah.
Okay.
He has a query also to say why
He has a
suffering
query.
under tension causes more infection.
Yeah. So, Prasenjit, well done. Good. You had a comprehensive talk. Now, it is very important to improve, which we will have to listen to all the criticisms also. The first thing is when you are presenting, don't just read the slides.
Yeah.
If it is just going to be reading the slides,
Yes.
then how would we know that you have understood what you're saying? You can put in 1 line or 2 lines, but you should be able to speak, let's say 10 lines on it by just putting in 1 line, which means you have a thought process. By just reading it aloud, it is not an active process. So this is not only for you, for everybody who is participating here. It's very important when you're presenting that don't read the slides alone. Just put in 1 line and expand it to 5 lines. That's number 1. Number 2, I'll try to test you whether you have understood what you have presented. So let's say a 30-year-old woman has an acute and is diagnosed as having appendicitis based on the CT scan and the counts, right? So you're going to make an incision on this patient. What is the kind of wound that you're going to inflict? based on the talk you mentioned?
Sir, it is clean wound, sir.
Clean. Patient has acquired
Clean.
appendicitis, count is high. How do you say it's a clean? If you go
Sir,
by your definition,
contaminated, sir. Clean contaminated, clean contaminated, as it is planned surgical wound, so it is clean and contaminated.
Good.
and
So
if it is perforated, if the appendix
Dirty
is
wound, sir.
perforated,
Perforated, it becomes dirty.
dirty wound.
great. So if I had to tell you, I was your patient and you are telling me that you have an appendicitis, and I want to know, doctor, what is my chances of having a wound infection with the open appendicectomy? What are you going to tell me?
Sir, open appendicectomy.
What are my chances? What are my incidence of wound infection?
It fall in clean and contaminated wound. So with prophylaxis, it 3 to 6%, and without prophylaxis, it goes up to 13 to 15%.
Yeah, but you give prophylaxis and probably continue the antibiotic depending on the situation. So 5% if it is clean contaminated, but if it has perforated, the chances goes to 15 to 40%. Correct?
Yes, sir. Yes.
Yeah. Okay.
Yeah.
That's fine. Number two, post-operatively, the patient that you operated had a infection in the round. You saw on the fourth day it became red, the wound became red, and now you had to cut a stitch and a plaster. What is of infection? Superficial, deep, or stage infection?
The wound area has become red, indurated.
Yes, sir. So
What do you think?
sir, deep,
As per your definition.
as it involves fascial layer, and
How do you know? How do you know it involves the fascial layer? By looking at the wound only. In fact, you have missed one important entity. I would have expected you to discuss necrotizing fasciitis. One of the important deep surgical infections is necrotizing fasciitis, which needs special mention, because you will be able to diagnose this entity. And necrotizing fasciitis is a spreading deep tissue infection, and that happens following number of surgical procedures. Understand? In the spectra, you have talked of deep tissue infection, you have not uttered the word necrotizing fasciitis.
yes,
Okay.
yes.
So if the wound is like this, straight away you cannot diagnose deep tissue infection. What do you do in such situation?
Sir, we have to open few sutures around the infective wound site, and to clean the wound site properly with normal saline, and regular dressing should be done too.
You are not saying what you have said in your slide. You said in your slide that bacteria should be grown in that.
And sir,
discharge.
yes, sir.
Then
Then
you just now describe what to do, what should be done for such situation, but you are
sir,
not saying that.
we have to send a pass for culture sensitivity also, and regular dressing and should be done.
When you suspect patient has got systemic sepsis,
So
patient, however, or the surgical infection may have systemic sepsis. What are the indicators of systemic sepsis?
sir, fever should be present, tachypnea, tachycardia, and systemic WBC count grows should be more than 12,000 or
Okay,
less
you
than.
already said patient will have SARS initially.
Yes, sir. Initially,
Patient who
sir.
have got systemic illness, SARS criteria have given.
Yes, sir.
And then if you are not controlling the infection, patient may go to
Systemic sepsis.
and you have described into some entity. When you say patient has septic shock,
Sir, septic shock when the map falls less than 60 mm of Hg, and
so hypotension.
hypotensive. Yes,
Patient
sir.
with SARS, patient with documented infection and shock.
Yes, sir.
You say patient septic shock.
Septic.
And severe sepsis is patient with other organ failure.
Other, sir, mods and.
So what you describe in your slide, you should be able to comprehend.
Sir.
Not a big.
Yeah. So coming back to how will you know whether it is superficial or deep or organ specific? You will wear a gloves, you will put in a finger and see if the fascial breakdown is there or not. That's a clinical test. But let's say that you had a suspicion that this patient has a breakdown of the fascia. Now, how will you know that this patient doesn't have a pelvic abscess, which is a organ space infection? How will you know?
So we have to do radiological USG or
Right.
Clinically,
So good.
any finding in clinically that you suspect patient may have pelvic abscess? Any symptom patient may have?
so rise of local temperature or
Local temperature, pelvis temperature, you should look at the perineum. Patient will have diarrhea.
yes.
Yeah.
Patient will have diarrhea. And if you do a parectal examination, you can appreciate a boggy feeling and tenderness. Okay, these are the clinical pointer to a pelvic infection or pelvic abscess.
Yeah. So you remember mucus diarrhea, passage of mucus, painful passage of mucus and a diarrhea that is characteristic of a pelvic abscess. Okay. Now, what organism do you expect in this wound? You have sent a culture. What organism do you expect from a post-appendicectomy wound?
So
Staph. No.
Staphylo.
No. What does the appendix contain? What organism?
Say E. coli. E.
So
coli.
that is not
Not
staph,
only
right?
E. coli, that is not only E. coli. There are a lot
Gram
of
negative, sir. Gram negative.
Gram-negative enteric
Bacilli.
pathogens,
Yes,
right?
yes, yes, sir.
Gram-negative bacilli. So you expect your microbiologist to report that I have seen a gram-negative
Gram negative.
bacilli. So she said, she or he says that yes, we saw a gram-negative bacilli. What is the antibiotic you will use now?
So we have to wait for cultures report to come.
that will take 3 days to come. Patient may have spreading infection. If you have patient having
Sir,
appendicitis
prophylactically we
infection,
can use third generation.
that is not
cephalosporin.
prophylactic. That is not prophylactic. Patient already infection. This is known as empirical antibiotic.
Empirical antibiotic. Yes, yes.
What is
So
that?
third generation cephalosporin, sir.
Will it cover all? What are you using? There are good number of antibiotics who are effective against gram-negative.
Yes, sir. We can use Pibzo or meropenem group of drugs.
Just like that.
Okay.
Would piperine tazobactam cover all gram-negative, including bacterides? What do you use in a common practice? Don't you add metronidazole?
Yes, sir. For anaerobic coverage, we can
So
add.
if you say only third generation cephalosporin, it did not cover. Cephalosporin has to be covered with aminoglycoside and metronidazole.
Metronidazole.
Okay. Okay. I think Makunda, we can move on.
Yeah. Okay. So the next presentation is by Dr. Aditi, who is a second year junior resident at Howrah District Hospital. Dr. Aditi, please share your screen.
Yes, sir. Hello, sir. Hello.
Yes.
Good morning, sir. Good morning, respected faculties. My topic is evaluation of patient with SSI. SSI can occur in any primary incision or a secondary incision in all those patients who are undergoing an operation with one or more incisions. There are certain risk factors and which determine the chances of SSI, like malnourished patient or obese, metabolic diseases like diabetes, hypertensive, immunocompromised states, poor perfusion or shock, foreign body material in the wound site, or poor surgical techniques. The host response, how the body is responds to the incision we have given the virulence factors, vasculature and the health of the tissue, presence of dead or foreign tissue in the body, in the wound, and the antibiotics we are giving. SSI assessment. For surgical wound assessment, several scoring systems are employed, like asepsis wound score, Southampton wound grading system. Now, these are the assessment scoring which enables us to grade the SSI in different criteria, and we give a numerical value to these scores, to these wound, and then this gives us a more objective assessment to assess the wound. Now here we can say, we can see the asepsis wound scoring. There are 7 criteria. If we have given any additional treatment like antibiotics for wound infection and debridement of the wound infection under local or general anesthesia, it's if for antibiotics we give 10 points. If we are debriding under local anesthesia, it's 5 points, and under general anesthesia, 10 points. Now, if there is serious discharge, for every day we add 0 to 5 points, and for purulent exudate we add up to 10 per day. Now, erythema we give 0 to 5 scoring. Separation of deeper tissues, if present, we give 0 to 10 score per day. If we culture isolate some bacteria from the wound site, 10. And if the patient is staying in the hospital for more than 14 days, as after the wound infection, after the SSI, it's given 5 points. Now, this serious discharge, erythema, and purulent exudate, and separation of deeper tissues, these are scored only for the first 7 days after SSI, and the remainder, rest of them are scored for from the day of SSI till 2 months. This is the Southampton grading system, wound grading system. It grades the wound into 5 categories. For normal healing, we give 0. For if there is mild, if there is some bruising, 1, some bruising or considerable, or there is erythema, then grade 1. Grade 2 is erythema with the other signs of inflammation, like at 1 point or around the suture line, or along the wound, or completely covering the around the wound. Now, grade 3 is there is some discharge, clear or purulent, clear or hemoserous discharge. Depending on the size, it's further graded. If it's less than 2 centimeter or more than 2 centimeter, or for more than 3 days. Now, if it's purulent discharge from only one side point from the wound, that's less than 2 centimeter, then it's given 4A, and completely along the wound, it's 4B. Now, if there is severe deep tissue wound infection with or without any tissue breakdown, and there is hematoma developing in the wound requiring aspiration, it's graded as 5. So this types of SSI, depending on the depth of wound infection, we have already seen. Sir, should I repeat?
No. You just say how to evaluate the patient. Patient having a surgical site infection, how do you assess the patient? What are the steps you take on? They are all discussed.
Yes, sir.
Your topic was to evaluation of a patient. That means clinical evaluation, imaging investigations.
Sir, first,
when do you suspect patient has got surgical site infection? Suspicion.
Sir, we will take swab from the
culture is lab. But you did not understand your topic. You are given a topic of evaluation of patient with surgical site infection. Evaluation means it's 2 components. One is the clinical evaluation. What we already discussed all these points. So when you are in the round, you should be able to identify the patient with surgical site infection, and treatment will depend on the evaluation. If slide on these points, what may be the local symptoms, signs, systemic symptom and signs, what investigation you order for this patient?
Sir, locally there will be erythema
Before that,
around.
before erythema, you have a dressing. You have a dressing, you came for a round.
Yes,
When
sir.
you suspect the patient might have infection,
So
what
there
goes
is-
wrong in the post-op period?
So there is wound soakage. Dressing soakage will be present.
Before soakage comes up, patient complain of pain.
Pain.
Some post-op pain is expected. If
Yes.
you have pain out of proportion, then you should suspect that something is wrong in the wound. Number one is pain. What else?
Sir, temperature raised.
Again, temperature raise may not be always there. If you have a simple cervical site infection, patient may, temperature is what? One of the symptom of systemic sepsis.
Yes, sir.
Patient may not have a wound discharge, but patient still may have SSI.
Yes, sir.
So once you suspect the patient might have some wound having SSI, then you open the wound. And then you've already mentioned what is there in the wound to suspect the patient has got infection. How you diagnose necrotizing fasciitis? What symptom patient may have with necrotizing fasciitis? What is necrotizing fasciitis?
Sir, infection of
What?
Infection involving both aerobic and anaerobic organisms.
This is a bacterial spectrum you're talking
Bacterial
of.
infection that breaks down the.
Clinically, when you suspect the patient may have necrotizing fasciitis, what happens to the patient? These are the patients who are very sick. These are the patients who deteriorate very fast. And this infection is not confined beyond the site of the wound itself.
Yes, sir.
What happens? We must have discussed this part. Okay. Dr. Beg, I think we can just discuss because she has not understood the topic. She cannot make it out.
Yeah. So basically, what you should be speaking on is on the evaluation. If you see a wound infection, what happens? But let me grill you a little bit to tell you how you should prepare. If I asked you, there is a patient, same patient, appendicectomy patient. On the third day, the patient has a temperature of 100 degrees Fahrenheit. How would you proceed to manage the case? So how will you answer this question? Give me an overview, then I will take details from.
Sir, I will send the blood culture routine CBC.
Off.
No.
You are in a government hospital. You're not in a corporate hospital. That's what you send septic profile.
Yeah, even in the corporate hospital nowadays, you can't do that. So Aditi, what you will say is history, examination, charts, tests. So how will we go about this? So history is about pain. Is there any pain in the wound? So we used to think like wind, water, and wound. These are three areas where there are common infections, right? So wind is lungs, water is urinary infection, and wound is wound infection. So three very common infections. So post-operative fever on a third day in a woman having undergone an appendicectomy, the fever, you will have to think of these things. So you take history of any cough, any shortness of breath, right? That will tell you about whether it's a pulmonary complication, is it a lung pneumonia. Then if you talk about wound pain at the site of the pain, at the site of the wound, is the pain more than natural? You do pain scoring and you see it's more than natural. Okay, fine. It's possible there's a wound infection. We'll have to take a look. Third, ask whether there is any burning sensation in the urine, or if there is a catheter already in place which can be responsible. So those will be your history. Take history of whether there is chill and rigor. There could be an associated malaria, a dengue. So take history of chills and rigors. So take first history. Then if the patient is diabetic or not, well, that's going to be important. Whereas the patient was on steroids for some other reason, that's important. Was the patient a smoker? Important. So those are the history. Then examination. Examination will be general examination and then a local examination. I will leave the general examination. That will obviously be the lungs and the abdomen and everything else as well. But the local examination is important, which means you're looking at the abdomen. Is there a rigidity? Is it a peritonitis? Is the wound looking red? Should I cut the stitches and look for pus? Or is there a big lump out here? So local wound examination is very important, and knowing what is going to, what information you will get. Then charts, which means pulse, respiration, temperature, blood pressure, urinary output. These charts are important to see. Because if there's tachycardia, tachypnea, you make a diagnosis of SIRS. There's tachycardia, tachypnea, low urinary output, plus you find that the temperature is very high, the blood pressure is less than 90, then systolic is less than 90. Is this not SIRS? Then it's going to a septic shock. So you make a diagnosis from the charts. Then what do you do? In examination, I forgot to mention that you must auscultate the lungs, but I'm just leaving the general part because I hope for the same constraint of time, you will understand how to answer these questions. Then after the charts, you say, I will send the following tests. What are the tests you will send? A chest X-ray, a urine culture, a count, and a wound swab, right? So these are at least a few things that we want to hear. You can even send blood culture after that. You can send other things as well. But at least we want to hear the common things. Then after this, we will talk about your management, your treatment, which means from here, apart from these tests, what other tests will you do? Oh, I could do an ultrasound. I could do a CT scan because I'm suspecting an organ space infection. Fine, that's also a possibility. And then management will come to what kind of infection you saw. Let's say your question itself, I would say, okay, now you diagnose this patient as a wound infection. How will you treat? Then you talk about superficial infection, deep infection, and organ-specific space infection, and tell me the treatment. So I'm just giving you an overview. Prepare yourself in this way, so that then, we will be able to understand that you understand the subject from a practical point of view.
So evaluation is patient evaluation means a clinical evaluation and a either some investigation which help in diagnosis of the infection itself. Okay.
Sir, I think I did not understand the topic.
Yeah.
Sorry,
Okay,
sir.
fine. So, but for other listener, you should be confining to the evaluation of patient. Number one, a general evaluation, the wound evaluation, and suspicion of organ space infection. In organ space infection, definitely need either a good ultrasound or CT scan. And then most important is to exclude systemic sepsis. If the patient has systemic sepsis, you need to treat the patient on emergent basis in a intensive setup. And then if there is a wound infection, that I hope the next speaker will speak on the management. How do you manage simple infection or complicated infections? So we pass on to Dr. Uma, who is a second year junior resident at SSKM IPG EMR, will present management of wound infection. Uma, you can share your screen. Milind, she has not joined.
So she has joined. So she told me she has joined.
Okay.
She's
Uma.
here, sir. Yes,
Yeah.
sir, she's here.
Uma, share your screen.
Hello.
Yes, please. You're audible.
Yes. Good morning, everybody. I'm presenting the management of surgical site infection. First, come to the prevention, that is pre-operative measures, operation theater measures, peri-operative measures, and the post-operative care. In the pre-operative measures, the first comes is the antiseptic bath day before the surgery, hair removal, clipping or using hair removal cream is better rather than the shaving. Pre-existing any skin infection must be treated before the surgery. Bowel preparation, antibiotic prophylaxis within 60 minutes prior to the incision as per the CDC guidelines. and repeat the dose in case of the prolonged surgery, like in prolonged bowel surgery. Proper hand washing before the surgery and use of sterile cap, mask, and gown. Cleaning of the skin before the incision with alcohol containing solutions over the adequate surface area. Now come to the operation theater measures, limiting the traffic in and out of the OT room, maintaining good humidity around 30 to 60% in the OT room, maintaining laminar flow of the ventilation, use of HEPA filters. These are high efficiency particulate air filters. Then maintaining pressure of the OT so that there can be a good laminar flow, good ventilation. Ensure use of sterile instruments and drapes. Now, perioperative measures like avoid hypothermia, avoid hypoxia during the operation, avoid hyperglycemia. We should try to maintain the sugar less than 200 and get gentle tissue care. Avoid excessive cautery. We should use bipolar. Bipolar should be preferred basically. Ensure good hemostasis. Avoid leaving any dead space while closing the abdomen or while closing any wound. Use drains when only necessary. And the closed suction drain should be preferred. And the drain should be inserted through a separate incision. Now, post-operative measures like keep the sterile dressing over the area, local area for 24 to 48 hours. Wash the hands before and after dressing. Use sterile dressing sets in the ward. Look out for any early signs of wound infection like the erythema or any induration, tenderness while dressing, patient complaining fever or not, patient complaining excessive pain while dressing or like that, and see whether is there any discharge, purulent or seropurulent discharge while dressing. So we have to look out for any early signs of wound infection. Then remove the drains, remove the urine catheter channel as early as possible. Start enteral feeding as early as possible for better nutrition. Then short hospital stay. Now coming to the treatment part, first we have to resuscitate the patient. If there is first resuscitate, then antimicrobial treatment in the treatment part, and then source control. Coming to the resuscitation part, adequate oxygenation, correction of the hypovolemia if there is hypotension, correction of hypothermia by giving the patient the warmer, correction of hypoglycemia with the insulin, and correction of if is there any fever, then we should use antipyretics. Now the antimicrobial treatment, there is we should start empirical therapy as when we detected that it's a surgical site infection. So empirical therapy with the broad spectrum antibiotic, and later it to be modified depending on the report, like culture and sensitivity report. Then in the superficial and deep infections, we should drain the site with by removing the sutures, by removing the staplers, and do the dressing. And then debridement if there is any slough tissue or any unhealthy tissue for better granulation. And we can use even negative pressure wound therapy also. In organ or any space surgical site infection, like USG guided, if there is any collection, then we can do USG guided percutaneous drainage for the intra-abdominal collections. And it's all depend upon whether it is multiloculated or uniloculated. Then we can go with the laparoscopic drainage also, and drainage by open method. Then source control, that drainage, debridement, and intra-abdominal lavage before closing the wound. and resection or elimination of gangrenous segment in the bowel surgeries. The initial dressing with the antiseptic solutions, and then once the contamination decreased, we can continue dressing with the normal saline. And that's it.
Yes. Uma, that was well presented, and I thought it was very well organized also, the entire talk. Makonda,
Yeah,
you would like to ask questions?
She has given the points clearly, but you could have elaborated a little more.
Agree.
So if you have a simple wound infection, superficial site infection,
Yes.
so in that case, what should be your measure? You see, in this patient does not have
if there is
shock or systemic sepsis.
So it's if it is a simple surgical site infection, if I am saying that only the superficial part is involved, only redness is there, or edema is there, or mild discharge is there, I will do normal dressing.
You take one of each out, send
out,
this
and then I will do
for culture
yes,
sensitivity.
if there is pus, then I will
Start on empiric
definitely
antibiotic, wait for the definitive result, and then continue. If the patient has got a spreading infection and there is large area of induration and patient has got features of systemic sepsis, you suspect patient has got a synergistic gangrene. What should be your measure?
So first we should resuscitate the patient.
Yes,
and
resuscitation with good volume replacement, resuscitation, then
resuscitation, better oxygenation, glycemic control.
yes.
Then after that we can took the measures of that local site, like whether we
What
have
local site? As I said,
like
in this situation, the infection is not confined only to your incision site.
Incision site.
So what is the
spreading.
most important aspect of management of this patient?
So if it is spreading to anterior abdominal wall, we can
Yes.
drain the collection.
It's not only drain, it's a necrotizing infection.
Necrotizing infection.
So only drainage is not going to help. So these are the patients who require major debridement.
Yes,
and
major
if you delay this debridement, the patient might deteriorate. Okay, so you have identify all the points, I agree, but there are some situations which need specific treatment. Suppose the patient has got a deep tissue space infection. Patient has got a pelvic abscess. How can you take care of that? Patient has appendicectomy and pelvic abscess. Yes. Patient has all the classic features. Patient has all the classic features, and you have documented by ultrasound and CT that patient has got a reasonable pelvic collection. How to manage that?
Pelvic. So if it is localized, then we can drain with the pictal catheter.
Yeah. So initially it should be a ultrasound guided.
Yes.
Aspiration.
Ultrasound guided aspiration.
Yeah. Or if it's a female patient, you can go by
the female patient
transvaginal drainage.
Yes, transvaginal in the pouch of Douglas. Yes.
Yeah. Okay. And then if it fails and patient has persistent infection, you can think of, you have already mentioned that, either a laparoscopic drainage or open drainage.
Open method.
Yeah, I think you have reasonably covered this management.
Yes.
Yeah.
I would just like to tell Huma, you should also know, since you mentioned so much, the Clavian-Dindo grade of complications. All right. Now, any paper that you will read will have complications will be graded by Clavian-Dindo. So I think the previous speaker or you should mention Clavian-Dindo rather than other grading, because this is universally accepted. And it basically means one is where there's a little bit of deviation, like a painkiller and an antipyretic. Grade 2 is where you required antibiotics. Grade 3 is where you required bedside dressing. 4th is an ICU care because of organ dysfunction. 5 is death. So we need to know these grade of complications, especially when you're talking about surgical site infection being the major contributor to complications apart from medical complications. So that is the one thing I wanted to add, but then otherwise, well done.
Yeah, Shaikh Muhammad has asked a question. Any suggestions regarding frequent pseudomonas infection in wounds and spectrum of antibiotic, usually empiric for this? So pseudomonas again is a gram-negative infection. Okay, and this is more common when you are doing some intra-abdominal procedure, particularly you are entering into the biliary tree or to the gut. So in these cases, what empiric antibiotic you should use when you suspect the patient might have gram-negative infection? We already discussed it.
Is third generation cephalosporin, metrogel, these are all gram-negative.
Aminoglycoside. Or now you have more alternatives like piperacillin tazobactam with metronidazole.
Yeah, in Pseudomonas, yes, Pibzo.
Yeah. So empiric antibiotic, in empiric antibiotic, you should use antibiotic which has known spectra of coverage of these gram-negative organisms. So idea of empiric antibiotic is to use antibiotic before the culture report came up. And you should think of antibiotic which covers these organisms. But again, you see, all antibiotic may not respond in a particular individual. Even if you think that patient has got gram-negative coverage and you give them, this patient may not respond, because that all depends on the behavior of this organism to the particular antibiotic. Okay. Any last comment, Dr. Beg?
No, I think that was well covered. The last talk was well covered. Yes, I think you could elaborate a little bit more as a practical example. At least I would request each one of the speaker to have a practical correlation. Make a case example at the end of your presentation and present as if, this is what you saw and this is what happened. That will give us an idea that you understand this subject from a practical point. That's the only comment I would like to.
Yeah, actually, this wound infection may be your ward round scenario. You will have a patient in the exam where you find the wound is kept open and there is some purulent discharge. And the whole ward round will go with this surgical site infection. So in that case, you need to define what is surgical site infection. You need to, nobody has mentioned this particular term, agent, host, and environment. You see, all infection is a interplay of the host, agent, and the environment. And you mention everything. You have mentioned about the host. What are the different host factors which determines infection? You have mentioned the organisms. Only mentioning organism are not enough. You see, some organisms which are our coloniform organisms may become virulent when you have diminution of the body resistance, particularly HIV infection or other patient on steroid therapy. And environment is very important. In hospital, environment starts from the indoor, a pre-hospital stay. The hospital environment, the ward itself, you should keep the infected patient in a different place, not keeping side by side. Second is the dress the patient is using, whether they are properly laundered or not. Okay, the food the patient is being supplied. And then come to the operative theater. So what I'm trying to say is all has been discussed, but ultimately the infection is the interplay of these three factors: agent, environment, and the host. Okay. So in the ward round, these are the things the examiner might ask you. And then the evaluation of systemic infection, evaluation for deep space infection, what investigation you would like to do, and then the management. Okay, so ward round scenario maybe for 5 or 10 minutes, but these are the usual things you discuss in ward round scenario. Okay.
Yes.
Yeah, I would like to add one thing, Makunda.
Yes, yes.
I think the negative pressure wound therapy should be added in the. I did not don't remember seeing a slide on it, because most of the deep infection will have negative pressure wound therapy. It should be a short note in the exam also, I think, nowadays, because of the importance. Maybe I missed it because I had
no, she has mentioned. Uma has mentioned.
Then it's okay.
NPWT.
Yeah, preferably put in a picture also, Uma, so that everybody understands how it looks like.
And again, you have to keep in mind that when you apply NPWT in a infection, you should ensure that the patient systemic infection is under control.
Yes.
Okay. Thank you. Thank you all.
Thank you, sir. Thank you.